Everyone who calls on the name of the Lord will be saved. First year-old question. If a drug has a low volume of distribution, like around 4.5 liters, the drug will be highly charged. So a drug that has low volume of distribution, such as aminoglycosides, will have high molecular weight, high plasma protein binding, high charge, and hydrophilicity. And this drug will be trapped in the plasma compartment. A drug with low volume of distribution will be, 4.5 liters because the normal plasma volume is 3 to 5 liters. If a drug has low volume distribution, it means the drug stays in the plasma and doesn't go into the tissues. And drugs that stay in the plasma are polar, hydrophilic, or highly charged. So aminoglycosides, something like this, they don't cross the membrane well. Myelofibrosis is a JAK2 mutation, same as polycythemia vera. The answer on USMLE, if they say teardrop-shaped RBCs or dry tap on bone marrow aspiration, the answer will be myelofibrosis. You will see massive splenomegaly in 100% of questions. They can also write it as teardrop-shaped poikilocytes. Poikilocytes just means abnormal RBCs, and that will be seen on more than 10% of the blood smear. It will be seen more than 10% on the blood smear. In myelofibrosis, the proliferation of abnormal cells in the bone marrow. In myelofibrosis, the proliferation of abnormal cells in the bone marrow, notably megakaryocytes and granulocytes, leads to the release of growth factors and cytokines that stimulate deposition of collagen, resulting in bone marrow fibrosis. Okay. A 63-year-old man with fullness in left upper quadrant and low hemoglobin and high uric acid and bone marrow aspiration shows dry tap. Diagnosis: myelofibrosis. You see massive splenomegaly, often seen in NBME. Hemoglobin can be low from myelocystic anemia, which is crowding of the bone marrow leading to anemia. Myelofibrosis due to JAK2 mutation, same as polycythemia vera. The student says, wait, but why high uric acid? Isn't that gout? Can be seen sometimes with increased cell turnover, including RBCs, because the precursors of RBCs have nucleic acid. 54-year-old man with massive splenomegaly and smear is shown. What is it? You see teardrop cells. The answer is myelofibrosis. answer is myelofibrosis. Also, the teardrop cells are known as dacrocytes. This is high yield from myelofibrosis. Key terms are massive splenomegaly, dry tap, and teardrop RBCs. In tetralogy of Fallot, there is going to be right ventricular, there's going to be increased right ventricular pressure, there's going to be decreased pulmonary artery pressure, and decreased pulmonary artery, there's going to be decreased pulmonary artery pressure and decreased left atrial pressure. So to recap, in tetralogy of Fallot, there's going to be increased right ventricular pressure, decreased pulmonary artery pressure, and decreased left atrial pressure. Why? In tetralogy of Fallot, there is a VSD. So in a VSD in the heart, blood always pumps from high to low pressure. So the blood is going to go from the left ventricular. Blood is going to go from left ventricle to the right ventricle, and so the right ventricle will increase in pressure due to the high blood that's coming in. So that's why right ventricular pressure increases. And then there is, in a tetralogy of Fallot, there is a right ventricular obstruction. If there's right ventricular obstruction, that means there's pulmonary stenosis, like the pulmonary artery is blocked. And so pulmonary artery is blocked, there's going to be decreased pressure in the pulmonary artery because no blood can go through from the right ventricle. And so there will be decreased pulmonary artery pressure. And then if there's decreased pulmonary artery pressure, there is by default going to be less left atrial pressure. So that's that. And now, if there is the VSD is repaired, what are the new pressure changes? The new pressure changes would be increased left ventricular pressure because the VSD is now blocked off, so the blood stays in left ventricle, and so left ventricle pressure increases. And then there will be decreased right ventricular pressure because the VSD is blocked. And if there's decreased right ventricular pressure, there is not enough blood going into the pulmonary artery or the left atrium. So you will also have left atrium pressure that is decreased. As seen here. So VSD is a hollow systolic, also known as a pansystolic murmur at the lower left sternal border. It can be associated with a diastolic rumble or enlarged left atrium. If more blood going from left to right across the VSD, then more blood is returning to the left atrium from the lungs. If more blood is going from left to right, so the left ventricle to the right ventricle, across the VSD, there is more blood in the right ventricle. the more blood is in the right ventricle, then the more blood is going to the lungs into the left atrium. This will cause left atrial dilation, which is why you will see left atrial dilation in tetralogy of Fallot. The four things you see in tetralogy of Fallot would be VSD, right ventricular hypertrophy, overriding aorta, and a pulmonic stenosis, which is pulmonary artery stenosis. If a VSD is repaired, USMLE once increased left ventricular pressure, decreased right ventricular pressure, and decreased left atrial pressure as the new changes seen in the heart. VSD does not cause cyanosis at birth. Only years later, after the higher blood flow to lungs, result in pulmonary hypertension, followed by right ventricular hypertrophy and reversal, right to left, which is Eisenmenger's. Murmur can be silent or soft at birth, followed by loud at 7 days of life. The assembly will ask why the murmur is louder now. Answer: decreased pulmonary vascular resistance. The lungs open up during the first week of life, resulting in decreased right pressure and an increase in the left to right pressure gradient. Okay, you see here, this is a VSD. You have the right side of the heart, which is the bad blood, goes from 73 in the superior vena cava to 73 in the heart, in the right atrium, and then it suddenly increases to 85, which can only be from the left ventricle. So the left ventricle donates some of his blood into the right ventricle. That's why it went from 73 to 85. And then the pulmonary artery now has good blood mixing with the bad. That's why this 85 transfers into the pulmonary artery, and then that goes into the lungs, and that will cause more good blood to come into the pulmonary veins, shifting into the left atrium, going into the left ventricle, into the aorta. Okay, so this is a VSD. Okay, so that's there. And this is what is going to be seen in tetralogy of Fallot. So we have to know anytime there's a shift in, like a jump from a right atrium to a right ventricle, you have to know it's a VSD. And this next one right here, this diagram would be Eisenmenger's syndrome, because what's happening is that there's normal right side of the heart and abnormal left ventricle. So what's happening is there's a reversal of flow from we have a reversal flow from right ventricle to left ventricle across the VSD. So in tetralogy flow, we had from right ventricle. We had flow. No, we had flow from the left ventricle to the right ventricle, because blood always goes from high to low. But then in tetralogy flow, we have blood going from So I would like to clarify what I said, because this is where we all get tripped up. So here it says, in Eisenmenger syndrome, we have a reversal of flow from the right ventricle to the left ventricle across the VSD. Eisenmenger's always starts off with a left to right shunt, meaning blood goes from the left ventricle to the right ventricle. And then, because there's so much blood in the lungs, it will cause the pulmonary hypertension, and it will switch. It will, before it was left to right shunt. Now it's going to be a right to left shunt because of the pulmonary hypertension. The lungs doesn't want to deal with all the blood, so it's going to switch it back. So there's be less blood in the lungs. So Eisenmenger starts with a left to right shunt, and this causes increased blood in the lungs. And then eventually the lungs can't take it anymore, and it switches. The lungs switch the shunt from the right ventricle to the left ventricle. That's why it says Eisenmenger's syndrome. We have a reversal of flow from right ventricle to left ventricle across VSD. Now, you have to know that tetralogy flow is always going to be a right to left shunt. See this. Tetralogy flow always goes from right ventricle to left ventricle. That's because there is a lot of pressure in the right ventricle, and it has to switch. Because of so much pressure and blood in the right ventricle, the blood is pushed into the left ventricle. And the reason there's increase in oxygen pressure here is because there is some blood that's going from the left ventricle to the right ventricle. There is some mixing, but the predominant flow is from the right side of the heart to the left side of the heart. Okay? So if there's a lot of blood going from the right side of the heart to the left side of the heart, that means that there's going to be less blood here eventually in the right ventricle, and that means there's going to be less blood in the pulmonary artery and less blood in the left atrium, which is why there is increased right ventricle pressure and decreased pulmonary artery pressure and decreased left atrial pressure in tetralogy FLO. If the VSD is repaired in tetralogy FLO, there will be increased left ventricular pressure, decreased left atrial pressure, and decreased right ventricular pressure. And then in tetrahedral fellow, that's in tetrahedral fellow. In Eisenmengers, the shunt is always going to be starting off from a left to right shunt, and because it's a left to right shunt, there's going to be increased blood in the lungs, causing pulmonary hypertension. And then the lungs will end up switching the shunt back to cope from left to right heart to right to left heart, and this will eventually cause decreased blood flow in the lungs. And the reason the kid is cyanotic at birth is because there is a right to left shunt. So some of that LV blood is mixing with the right, and the kid can't get enough blood to the kid can't get enough oxygenated blood to the body. Tetrahedral fellow, you have pulmonic stenosis, you have right ventricular hypertrophy, overriding aorta, and a VSD. If you're asked which component most determines prognosis, the answer is the degree of pulmonic stenosis. The child will not be cyanotic at birth, but then years later will develop Eisenmenger syndrome. Reversal of left to right shunt over the VSD to be right to left shunt, and cyanosis, where the stem gives a school-age kid who squats on the playground to relieve symptoms. Squatting increases afterload, which increases LV pressure, which decreases the pressure gradient of the right to left shunt, thereby mitigating cyanosis. Squatting also increases preload by increasing venous return back to the right heart, but it is the effect of increased afterload that is most related to the decrease in symptoms. Pulmonic stenosis is seen in tetrahedral fellow, described as mid-systolic murmur, or just regular systolic murmur that increases with inspiration. Remember, right-sided murmurs increase with inspiration. And the pulmonic stenosis will be at the left sternal border, second intercostal space. Young child with hypocalcemia and harsh systolic murmur at the left sternal border. Diagnosis: DiGeorge syndrome associated with tetralogy fellow. On the USMLE, you should essentially think of tetralogy fellow and DiGeorge syndrome as interchangeable. You can by all means get other heart defects in DiGeorge, truncus arteriosus, but I can emphasize enough that tetralogy fellow is almost seen in DiGeorge on USMLE. Next, a stab to the laterally directed anterior chest wall at the fifth intercostal space along the left MCL line. What does this injure? This is the left lung. So a stab to the laterally directed anterior chest wall at the fifth intercostal space along the left mid-clavicular line. What would that pierce? The answer is left lung. A more medial stab would have stabbed the left ventricle. Next question. Heavy, painful menstrual bleeding and large tender uterus. What is this? This is adenomyosis. So heavy, painful menstrual bleeding and large tender uterus. This is adenomyosis. It's common in multiparous women, so women who had a lot of kids. You see endometrial glands and stroma within myometrium. You see endometrial glands and stroma within the myometrium in adenomyosis. Next, pituitary adenoma arises from the anterior pituitary. Anterior pituitary is from surface ectoderm. So, the next question is, what supplies the right lower lobe liver mass? What supplies the right lobe liver mass? The answer would be right hepatic artery. What is the breakdown? First you have the celiac trunk, then you have the common hepatic artery, then you have the proper hepatic artery, then the proper hepatic artery splits into right hepatic and left hepatic artery. Right hepatic artery supplies the right lobe liver mass. Next, lady presents with skin rash, joint pain, renal failure. She has a decreased C3 and a decreased C4 and normal factor B level, which triggered what triggered the complement activation. She has IgG antigen complex formation because she has SLE. Most common cause of complement deficiency is autoantibodies, which activate classical complement system after binding host antigen. So there is a decreased C3 and C4 because autoantibodies don't activate alternate complement cascade. Factor B is normal. So if somebody presents with skin rash, joint pain, renal failure, and has decreased C3 and C4 and normal factor B levels, she has SLE, and you're going to see IgG antigen complex formation. Okay, next we have proximal humerus and glenohumeral joint get blood supply by anterior and posterior circumflex humeral arteries, which are branches of axillary artery that form an anastomosis at the neck of humerus. So the proximal humerus and glenohumeral joint get blood supply by anterior and posterior circumflex humeral arteries. which are branches of the axillary artery that form an anastomosis at the neck of humerus. So the humeral neck fractures lead to avascular necrosis of humeral head. Next, retrosternal burning point, adenophagia, and punched out ulcers on proximal esophagus, and normal appearing gastroduodenal mucosa after taking doxycycline for 1 week. This is a drug-induced direct mucosal injury. This is from pale esophagitis. So you have to drink lots of water and sit upright after ingesting the pill. NSAIDs, tetracyclines, bisphosphonates can all cause this. So taking doxycycline for 1 week can cause retrosternal burning pain and adenophagia, which is painful swallowing, and the doxycycline can also cause punched out ulcers on the proximal esophagus. So doxycycline belongs to the tetracycline drug class. What is the mechanism of action of doxycycline? Doxycycline targets bacterial ribosomes. It targets a 30S subunit of the ribosome. Doxycycline targets the 30S ribosomal subunit of the bacteria. Bi at 30 and cell at 50. A and T stand for A stands for aminoglycosides, T stands for tetracyclines. So bi at 30, 30 stands for ribosomal subunit. Next. An agent is applied to human cells that activate G protein dependent phospholipase C, which will intracellularly increase after exposure to this agent. The answer is calcium. Phospholipase C is activated, and IP3 activates protein kinase C by increasing calcium in the cell. So an agent comes into the cell, the agent activates phospholipase C. Phospholipase C cuts a fat molecule called phosphatidylinositol 4,5-bisphosphate into two pieces. Those two pieces, the first one would be inositol 1,4,5-triphosphate, and the second piece would be diacylglycerol. The inositol 1,4,5-triphosphate goes into the cell and tells the ER to let the calcium out. The glycerol, which is the second part of the thing that phospholipase C cuts into two, the diacylglycerol stays in the cell membrane and works with calcium to activate protein kinase C. The main thing is that increases inside the cell after this is calcium. Next, preeclampsia. That's where you have hypertension with headache and visual changes, and you see scotomata, which is areas of partial vision or complete loss of vision. It's like you have blind spots when you look. So that's scotomata, and you see that in preeclampsia. And you see increased vascular permeability and decreased end organ perfusion in preeclampsia. Preeclampsia is due to retinal artery vasospasm. Remember that, retinal artery vasospasm. Next, patient with latex agglutination tests positive for soluble polysaccharide antigen. And the CSF shows increased protein concentration and pleocytosis and headaches and confusion. And there is a history of viral esophagitis and PCB pneumonia. So the question is asking patient with latex agglutination tests. Patient with latex agglutination test positive. Patient with latex agglutination tests positive for soluble polysaccharide antigen, and the CSF shows increased protein concentration and pleocytosis and headaches and confusion and history of viral esophagitis. Pleocytosis is when you have increase to WBC in the CSF. And this patient had viral esophagitis and PCP pneumonia. Like they had a history of viral esophagitis and PCP pneumonia. This patient has meningoencephalitis from Cryptococcus neoformans. You will see round or budding yeasts. So pleocytosis can mean increased lymphocytes or neutrophils, depending on the cause. Here they just say pleocytosis. That can mean increased lymphocytes or neutrophils, but in fungal meningoencephalitis, you will see increased lymphocytes, not neutrophils, increased lymphocytes, increased protein, and decreased sugar. This is the second chart of that red chart. This is the second column of that red chart. First you have bacteria, then you have fungal, then you have viral. And in this, fungal is in the second column. Fungal would present with lymphocytes, increased protein, and decreased sugar. So in Cryptococcus neoformans, you will see rounder bodies. Next, ED is common for men as they age. So erectile dysfunction is common for men as they age. A patient comes to you um, talking about that, um, like erectile dysfunction, just say it's good you mentioned. In this sense, ED is common. You have to tell them erectile dysfunction is common for men as you age. It's good you mentioned to the patient to make them feel more comfortable. Next, DSC occurs in the setting of sepsis, which is caused by gram-negative bacteria. You will see plasma fibrinogen values decrease, and you see RBC fragmentation on a peripheral blood smear. So you will see plasma fibrinogen values decrease, and you see RBC fragmentation on peripheral blood smear in DIC. Next, apixaban is given for stroke prophylaxis in patients with atrial fibrillation. Apixaban blocks active sites of factor Xa, which blocks conversion of prothrombin to thrombin. Atrial fibrillation patients put on metoprolol and apixaban to control ventricular tachycardia. So AFib patients put on metoprolol and apixaban, and the metoprolol is to control the ventricular tachycardia. So then there will be decreased dizziness, and the apixaban is given for anticoagulation. What does apixaban do? Apixaban blocks the active site of factor Xa, which blocks conversion of prothrombin to thrombin. And apixaban is given for stroke prophylaxis. Next, spina bifida and estrogen syndrome. They both have multifactorial inheritance pattern. Next, in cold weather, body increases metabolic rate, so there will be heat production by increasing sympathetic activity, which increases catecholamine release. And you will see peripheral vasoconstriction to shunt blood away from the skin and to increase muscle tone, increase shivering, and to increase thyroid function so the BMR can go up. Okay, so in someone who is stuck outside, the body wants to produce more heat. And how do you produce more heat? By increasing the sympathetic activity, so that you can have more catecholamine release, and this would cause peripheral vasoconstriction. The answer here is peripheral vasoconstriction seen in somebody with hypothermia. The reason you have peripheral vasoconstriction is because you want to shunt blood away from the skin so that you can have increased muscle tone, increased shivering, increased thyroid function, and so the BMR can go up. This is what's seen in hypothermia. In hyperthermia, HYPER thermia, the body vasodilates and there's planchnic vasoconstriction, diaphoresis, and decreased thyroid function. So in hyperthermia is someone who's overheating during a heat stroke. The body, the vessels vasodilates. There is planchnic vasoconstriction, diaphoresis, and decreased thyroid function because the body is trying to preserve its energy. Planchnic vasoconstriction means the narrowing of the blood vessels that supply the GI tract, spleen, pancreas, and liver. So basically, the blood vessels that supply our internal organs. And so the body redirects blood away from the abdominal organs toward the heart, brain, and skeletal muscles, which are much more important when there's an emergency. You want to preserve your brain, you want to preserve your heart, and you want to preserve your skeletal muscles so you can run away. So, yes. Okay. So, in short, splanchnic vasoconstriction is tightening of the abdominal organ blood vessels to save blood for the brain and heart in emergencies. Next. So, before we go on, you have to remember in hypothermia, when there's extreme cold weather, you're going to have peripheral vasoconstriction, which means like this blood vessel supplying the skin. Those blood vessels are going to vasoconstrict. But in hyperthermia, when it's like 105 degrees outside, your body will do splanchnic vasoconstriction. It will vasoconstrict the blood vessels to your internal organs in your tummy so that your heart and brain don't fry. Okay, next. 1018. A week-old boy presents with urosepsis and diffusely thickened bladder with bilateral vesicoureteral reflux and hydronephrosis. This is due to what? A week-old boy presents with urosepsis and diffusely thickened bladder with a bilateral vesicoureteral reflux and hydronephrosis. Urosepsis is when A UTI spreads to the bloodstream, causing sepsis. Okay, so this kid, baby, has sepsis from a UTI and a thickened bladder with bilateral vesicoureteral reflux and hydronephrosis. This is due to what? This is due to persistence of urogenital membrane. This is because of incomplete canalization and defined by persistent urogenital membrane that obstructs the urethra. So this is because of incomplete canalization and defined by persistent urogenital membrane that obstructs the urethra. So what this is saying is that there's a persistence of the urogenital membrane. Basically, for boys, you can't pee at all. Persistence of the urogenital membrane means the opening for urine or vaginal flow does not form, leading to obstruction in an infant. This is particularly dangerous for boys because uh, they pee out of the urethra, and that part is blocked. And then in girls, it blocks off the vaginal flow. Girls also pee through the urethra, but that part, the urethra, is not blocked off in girls. Only the vagina is blocked off in girls when they have persistence of the urogenital membrane. So basically, period blood and secretions get trapped. No, when it's girls, but for girls, they can pee out of the other hole, so it's they pee out of the other hole, so it's okay. And for boys, it's dangerous because they only have one hole to pee out of. You'll understand eventually what I mean. Okay, so the guys can only pee out of that one hole that's blocked off. In girls, the vagina is blocked off, but of course we pee through something else, so that's there, it's open, but the period blood will get trapped. Okay, so for boys, persistence of the urogenital membrane um, it traps urine because you can't pee, and then it builds up, goes all the way to your kidneys, causing hydronephrosis. Okay, next, and sepsis. Next, you have recurrent focal onset seizures evolving into bilateral tonic-clonic seizures over past months. She also has headaches. She has tangle of large blood vessels with thickened walls. So basically, she has AVM. She has AVMs. AVMs show bag of worms appearance and dark flow voids. So AVMs looks like a bag of worms. And if you have AVM, the blood goes directly from the arteries to the veins. So this lady, she has recurrent focal onset seizures evolving into bilateral tonic-clonic seizures over the past few months. She also has headaches, so which means she has a tangle of large blood vessels with thickened walls. Next, anaphylaxis. This is mast cell and basal cell degranulation. Histamine and tryptase gets released. Tryptase is what's seen in the mast cell that gets released. Next, in anaphylaxis, IgE receptor on the mast cell binds circulating IgE antibodies. Multiple IgE antibodies become cross-linked. This results in aggregation, keyword aggregation, of FcR1 receptors on the mast cell surface, and then you get degranulation. So what happens first? First you have anaphylaxis. So when you have anaphylaxis, the IgE receptor, which is on the mast cell, binds the circulating IgE antibodies. The IgE receptor on the mast cell binds circulating IgE antibodies, and then multiple IgE antibodies become cross-linked to the IgE receptors on the mast cell. This results in aggregation of FcR1 receptors on the mast cell surface. Then you have the degranulation. This is what causes anaphylaxis. Next, there is an increased incidence of cancers in women. First you have the breast, lung, and then colorectal cancer. So this is what's most commonly seen in women. The first one would be breast, then lungs, then colorectal cancer. Next, increased mortality in women. What kills women the most? It's lung cancer. Then it's breast cancer. Then it's colorectal cancer. Lung cancer is the worst. The shit will kill you. Mainly because the screening is the same as it was years and years ago. So that's that. Next, 1023. If somebody has depression, fatigue, hypersomnia, and vivid dreams, this is cocaine withdrawal. So if somebody has depression, fatigue, hypersomnia, and vivid dreams, you will see cocaine withdrawal. Next, heme synthesis happens in the mitochondria. Next, type 2 pneumocyte they do the regeneration of alveolar lining and surfactant production. Type 2 pneumocyte do generation of alveolar lining and surfactant production. So type 2 pneumocytes make surfactant, and they also do the regeneration of the alveolar lining. The key word here is regeneration of alveolar lining. Next, genomic imprinting is caused by DNA methylation, where genes can be silenced by adding methyl groups to cytosine residues in the DNA molecule. So genomic imprinting is caused by DNA methylation, where genes can be silenced by adding methyl groups to cytosine residues in the DNA molecule. What is that? Genomic imprinting is caused by DNA methylation, where genes can be silenced by adding methyl groups to cytosine residues in the DNA molecule. So next we have neurosyphilis, which causes headaches, memory loss, pleocytosis. Remember we said pleocytosis means increased WBC in the CSF. That can either be neutrophils or it can be lymphocytes. So in neurocephalus, you have a headaches, memory loss, and pleocytosis, and cardiovascular syphilis. You have a loud S2 and ascending aortic arch calcification. You see gammas here. Gammas. Looks like look like large, like they look like large holes in your face. Rubber. It looks like rubber. It happens about 15 years after an initial infection. And gammas are seen in neurocephalus. And you also see ascending aortic arch calcification in neurocephalus. Next, you have GnRH from the hypothalamus. This causes release of FSH and LH from gonadotropes of the anterior pituitary. LH triggers testosterone release from Leydig cells of the testes. FSH triggers release of inhibin B from Sertoli cells of testes. If FSH is high and LH is normal, then inhibin B is low because lack of negative feedback from inhibin B on FSH production release results in increased FSH. So GnRH is released from the hypothalamus. This makes the anterior pituitary release FSH and LH. LH triggers testosterone release from the Leydig cells of the testes. So the Leydig cells are in the testes. LH from the anterior pituitary triggers testosterone release from the Leydig cells of the testes. FSH from the anterior pituitary triggers release of inhibin B from the Sertoli cells of the testes. If FSH is high and LH is normal, then inhibin B is low. If FSH is high and LH is normal, then inhibin B is low because lack of negative feedback from inhibin B on FSH production results in increased FSH. So basically what they're saying is if FSH is high and LH is normal, then inhibin B is low. Yeah, because let's say the body doesn't have enough inhibin B, that's going to tell the anterior pituitary to make more FSH, and so the anterior pituitary will make more FSH. However, there's a problem translating from FSH to inhibin B, so inhibin B stays low. but this doesn't really affect the LH at all because LH is released from the anterior pituitary, but LH acts on the Leydig cells of the testes. LH, Leydig. Think of LH and think of Leydig cells of the testes. FSH is always paired with inhibin B from the secretory cells of the testes. Next, you have to know that D-xylose absorption test will be normal after pancreatic resection. D-xylose absorption test will be normal after pancreatic resection. Next, give lisinopril for worsening diabetic neuropathy in patients with proteinuria. ACE inhibitors and angiotensin II receptor blockers preferred in diabetics with albuminuria to slow progression of diabetic nephropathy. Okay, so lisinopril. Give lisinopril for worsening diabetic neuropathy. What are the lisinopril? Lisinopril is given for worsening diabetic neuropathy in patients with proteinuria. Lisinopril is what? It's a blood pressure medication. You give it for people with diabetes that also have kidney failure. So give lisinopril for worsening diabetic neuropathy in patients with proteinuria. ACE inhibitors and angiotensin receptor blockers preferred in diabetics with albuminuria to slow progression of diabetic nephropathy. What are the ACE inhibitors? The ACE inhibitors are angiotensin converting enzyme inhibitors that end in pril. So lisinopril is an ACE inhibitor, and it's given for worsening diabetic neuropathy in patients with proteinuria. Angio2 receptor blockers are what? There are anything ends in certain. Candacertin, erpocertin, losartan. Okay. Next, in RPGN on light microscopy, you see crescent formation.